Thank you for joining us. We'll discuss how to perform a mechanistically based, patient-specific, customized ablation for atrial fibrillation. By recognizing AFib mechanisms in the EP lab, we'll know when to use pulmonary vein isolation, linear lesions, CFAE ablation, rotor ablation, when to isolate the left atrial appendage and coronary sinus, and when to target spatiotemporal dispersion. With a better understanding of fundamental mechanisms and how various ablation approaches address these mechanisms, we'll be better able to recognize the origins of AFib in our individual patients and perform a more customized ablation procedure with better outcomes. Here are my disclosures. None are relevant to this presentation. Here's a disclaimer statement. This presentation is intended to give general information. How you use this information to treat your patients is entirely up to you and is your responsibility. Which patients should be referred for advanced management of atrial fibrillation? This is the patient that I want referred to me. Anyone less than 80 years of age who is not satisfied with medical management is a candidate for AFib ablation. The fewer the comorbidities, the better. However, even patients with substantial comorbidities should be offered the procedure. We like to complete all AFib ablations prior to age 80. Because procedural complications increase with age and markedly so beyond age 80. This is why this cutoff is used. The elderly are less able to withstand the procedure. Even when no procedural mistakes are made per se, a wide variety of major and minor complications can and do occur. So my sweet spot for AFib ablation is age 70 to 75. We get very good results and these patients tolerate the procedure very well. Also, there's still time for another ablation if needed before the age 80 cutoff. We know that ablation complications drop when operators perform at least 25 procedures per year. Inexperienced operators can also benefit from working in experienced labs where at least 50 to 100 procedures are performed per year. Ablation is a team effort. Atrial fibrillation matters to patients. This is why we do this. Our patients suffer from symptoms of palpitations and fatigue, which can be debilitating. Also, AFib causes stroke, which increases with age in the presence of additional comorbidities. Here's an unfortunate case from our hospital. At age 88, Mrs. R was happily enjoying retirement, sitting on her swing on her back porch, when suddenly this happened. She suffered an embolic stroke, leaving her paralyzed on her right side with an expressive aphasia, meaning she can understand but she can't communicate back. She received a PEG tube for feeding because she could no longer swallow and was waiting to be transferred to hospice. Her ECG showed AFib, which was a new diagnosis. AFib has serious consequences. There's a 5-fold increased risk of stroke with AFib, and AFib accounts for 36% of strokes in our population aged 80 to 89 years. And strokes due to AFib are more disabling, more likely to recur, and more likely to be fatal than strokes due to other causes. AFib is also associated with a 3-fold increased risk of heart failure, 2-fold increased risk of heart attack, 2-fold increased risk of dementia, and 2-fold increased risk of death. This is serious business. AFib is a huge problem that is growing fast. Over 3 million people in the United States have atrial fibrillation now, and that number is expected to reach over 12 million in the US by 2050. This includes 5% of the population over age 65 and 10% of the population over age 75. So AFib is becoming the latest epidemic, much like high blood pressure and diabetes. When folks hear about AFib, many suspect that they are having episodes, and this can be very tricky. Symptoms can range from non-existent to debilitating. Classic symptoms include palpitations, which is the sensation of a rapid heartbeat, fluttering, pounding, or floppiness in the chest, or simply feeling out of rhythm. The most common symptom from AFib is fatigue, which results from the rapid rates, rhythm irregularity, and compromised hemodynamics due to impaired atrial transport and variable ventricular filling. The degree of fatigue corresponds to the duration of the AFib episode and overall rate control, with much more rapid rates being more exhausting over time. Sustained rapid rates can be like running a marathon that never ends, as the energy expenditure for the heart to support the tachycardia is substantial. Even our patients wonder if that funny feeling is necessarily their atrial fibrillation. We know that symptoms are unreliable in predicting the presence of AFib. 95% of AFib episodes are asymptomatic. Symptomatic episodes are incorrectly attributed to AFib 85% of the time, and even individuals known to have symptomatic episodes of AFib have asymptomatic episodes over 10 times more frequently. We know that those with anxiety and depression tend to overestimate their AFib, while those with increased age and female gender tend to underestimate AFib. These features can inform our discussions with patients. Our patients care about two things: relief of symptoms and protection from stroke. To address both of these concerns, we strive for rhythm control, either with antiarrhythmic medications or catheter ablation, to help our patients achieve their healthcare goals. We know that the risk of stroke due to AFib increases with increasing AFib burden. This 2015 study demonstrates how the risk of stroke is highest for permanent AFib, lower for persistent AFib, and lowest for a paroxysmal pattern of AFib. It seems reasonable that if we can lower AFib burden, even partially, then stroke risk will also be less. This doesn't change anticoagulation recommendations necessarily. It may still be necessary to take blood thinners. However, we know that some AFib patients will stroke even while taking appropriate anticoagulation, so reducing stroke risk by promoting sinus rhythm is still important. The CASTLE-AF study, first presented at the European Society of Cardiology 2017, provides the most convincing evidence for the benefits of AFib ablation, demonstrating mortality, stroke, and CHF benefit in heart failure patients with LV ejection fraction less than 35% and ICDs already implanted. The presence of an ICD confirms the severity of the cardiomyopathy and allows for documentation of AFib burden. CASTLE-AFib emphasizes the importance of maintaining sinus rhythm in our sickest patients, hopefully bringing an end to the argument that rate and rhythm control are equivalent. AFib ablation does reduce symptom burden, stroke, heart failure hospitalization, and all-cause mortality. Because of CASTLE-AF, AFib ablation may become the standard of care for heart failure therapy. It should be noted that RF ablation was used exclusively in this landmark trial. There was no use of the cryoballoon. Here we have the guideline indications for AFib ablation from AHA/ACC HRS 2014. Basically, AFib ablation may be performed for any pattern of AFib, paroxysmal, persistent, or long-standing persistent, with encouragement to try antiarrhythmic medications prior to ablation. We consider ablation for patients who are sufficiently symptomatic, not excessively comorbid, eligible for anticoagulation, and who have failed or declined antiarrhythmic drug therapy for any legitimate reason. Most patients referred to me for AFib ablation are in a persistent or long-standing persistent pattern, so I am very aware that I can ablate persistent AFib after a trial of antiarrhythmic medication as a 2A indication and without a trial of antiarrhythmic medication as a 2B indication. We can also ablate long-standing persistent AFib after a trial of antiarrhythmics as a 2B indication. Patients inevitably ask, what is atrial fibrillation and why do I have it? This is a simple question, but without an easy answer. To give a superficial answer, in sinus rhythm on the left, there's an orderly progression of electrical activity across the atria that causes the atrial chambers to contract in an effective and coordinated fashion. During atrial fibrillation, electrical activity is chaotic with independent electrical wavelets and wavefronts swirling throughout both chambers, resulting in highly irregular patterns of activation with rates ranging from 300 to 600 beats per minute in the atria. This activity is transmitted to the ventricle across the AV node, which filters the rate, such that the overall heart rate is slower, typically 100 to 180 beats a minute, while the irregularity is preserved. Let's review historical perspectives on AFib, which lead to the modern conceptual paradigms. In the early 1900s, three major mechanistic theories were proposed. Each of these has relevance today and may account for AFib in certain patients. No single explanation explains all episodes in all patients. The first is known as mother wave reentry. and proposes that there is a reentrant circuit somewhere in the atria which is relatively stable and sends wavefronts of activation outward. These wavefronts fragment and break up as they propagate across the electrically heterogeneous and structurally discontinuous atria, resulting in fibrillatory contractions where individual muscle bundles appear to be contracting independently. The second mechanism is known as multiple circuit reentry. Multiple circuit reentry postulates that there is no stable mother rotor, but rather the atria are filled with independent wavelets of electrical activity that are constantly multiplying. It's the rapid multiplication of these short-lived wavelets that sustains fibrillation. Finally, there's the concept of a rapidly discharging ectopic foci. As with mother wave reentry, emanating wavefronts fractionate into independent wavelets and cause fibrillation. We now know that each of these paradigms is valid and explains the mechanism of fibrillation in certain cases. Recognizing these mechanisms during an ablation procedure can help tailor the procedure to address each patient's unique substrate for fibrillation. We now recognize the importance of the pulmonary veins for both the initiation and maintenance of AFib in many cases. As shown in panel A, a trigger focus within a pulmonary vein can send electrical impulses to the atria, resulting in tachycardia. Panel B shows that impulses from a pulmonary vein can spread with fibrillatory conduction across the atria, manifesting as AFib. Furthermore, in panel C, if the pulmonary vein trigger stops firing, AFib may be sustained independently by reentrant activity occurring within the atrial chambers. The cornerstone of AFib ablation is pulmonary vein isolation, such that pulmonary vein triggers will not escape to the muscle chamber. When pulmonary vein isolation is performed at the level of the vein antra rather than the vein ostia, the ability of the atrial chamber to support AFib is also attenuated. This figure, put forward by the Heart Rhythm Society in 2007, summarizes our current understanding of the major mechanisms contributing to AFib. Panel A shows triggers, mainly within pulmonary veins, but also scattered throughout the atria, which may both initiate and perpetuate AFib. Panel B shows rotors, which are spontaneously sustained reentrant circuits occurring anywhere in the body of the atria or muscular sleeves extending into the pulmonary veins, and which function independent of any triggers or ectopy arising from the pulmonary veins. Panel C illustrates how all of this activity is heavily modulated by the autonomic nervous system. The nervous innervation of the heart is incredibly dense. Sympathetic effects are typically more diffuse, whereas parasympathetic activity is highly localized and specific. Parasympathetic effects, mediated by an acetylcholine-activated potassium channel, can shorten the refractory period of atrial tissue to less than 1/4 of baseline measurements, dramatically increasing the proportion of excitable tissue available to support multiple wavefronts simultaneously. Maximal vagal discharge is powerful enough to cause complete electrical standstill in the atria due to an overwhelming hyperpolarization. So autonomic effects are extremely powerful and not to be underestimated. For any episode of AFib, we imagine that all of these mechanisms are potentially at work simultaneously. Outside of the EP lab, it's not possible to know which mechanisms are present. An ECG diagnosis of AFib really can't tell you anything about the mechanism. Descriptive labels such as coarse AFib or fine AFib or AFib flutter contribute very little. For paroxysmal AFib, pulmonary vein triggers are thought to be the dominant mechanism. For persistent AFib, substrate-based reentry is felt to play a more prominent role, even fully supporting AFib without any contribution from the pulmonary veins. Inside the EP lab, mechanisms of AFib are discernible to a certain degree and can be used for a customized ablation procedure. For both paroxysmal and persistent AFib, pulmonary vein isolation remains the backbone of the ablation procedure in most labs. Recent studies argue that pulmonary vein isolation alone is sufficient for persistent AFib in patients who do not have any structural heart disease. Such patients are very different from the CASTLE-AF cohort. Alternately, some very experienced and successful operators maintain that pulmonary vein isolation is never needed, including Dr. Kunlawi Nadamani with CFAE ablation, Dr. Sanjeev Narayan with rotor ablation, and Dr. Jerome Halifa targeting spatiotemporal dispersion. Let's explore each of the major contributors to AFib individually, beginning with fibrosis and scar. Here's a figure from Dr. Stanley Natel, World Authority on AFib Mechanisms, published in Circulation Research 2017. This figure reminds us that AFib is part of a progressive atrial cardiomyopathy. Patients develop risk factors, including obesity, hypertension, sleep apnea, and cigarette smoking, which influences cellular signaling to promote atrial structural changes and fibrosis, with these changes nuanced by individual genetic variants. Dr. Akum, now at the University of Washington, used MRI to define atrial fibrosis and define the Utah stage for reporting percent atrial fibrosis. He showed that AFib progresses from paroxysmal to persistent as atrial fibrosis increases, and that the degree of fibrosis predicts recurrence of AFib post-ablation. For Utah stage 3, freedom from AFib is only 50% at 1 year post-ablation. For Utah stage 4, AFib freedom is only 12.5%. These statistics should be discussed with patients, with ablation potentially discouraged for Utah stage 4 patients. The challenge is that cardiac MRI is not readily available and that scans represent an additional cost. AFib ablation is typically offered based on symptoms and a patient's ability to tolerate the procedure, which I believe is appropriate. In the ARREST-AF study, which was conducted in Australia, we learned that risk factor modification improves the long-term success of AFib ablation by partially reversing the atrial cardiomyopathy that develops due to the presence of these risk factors. Risk factors addressed in ARREST-AF included weight loss, blood pressure control, glycemic control, and lipid profile. The results were astonishing, demonstrating a 5-fold improvement in ablation success as judged by the frequency, duration, and severity of symptoms from AFib post-ablation. Here is how the progression takes place. In the blue column, we see how a collection of risk factors cause atrial structural, electrical, and autonomic remodeling, creating the substrate for AFib. AFib develops, which is then treated with catheter ablation. Post-ablation, the ongoing presence of these same risk factors results in ongoing progression of the atrial cardiomyopathy, predisposing to recurrent AFib and ultimately determining the final ablation outcome. In the red column, we see that risk factor control results in substrate modification, including reversal of atrial fibrosis, such that AFib burden is reduced. Following AFib ablation, ongoing risk factor management continues to slow progression with ongoing reversal of the atrial cardiomyopathy. This reduces AFib recurrence, making the ablation procedure more successful. We were inspired by the results of ARREST-AF. Like many cardiology programs, we lack the resources for close follow-up and interdisciplinary support to replicate the ARREST-AF protocol. As a substitute, we routinely recommend a Mediterranean diet to our patients, which has been shown in numerous studies to be a heart-healthy diet. We give our patients printed guidelines, which we published in EP Lab Digest in 2016. A Mediterranean diet for optimal heart health, extending the results of ARREST-AF to all our patients. EP Lab Digest, June 2016. Others are welcome to provide these materials to their patients. Our next topic is rotors and wavelets, complex electrical dynamics for which patients with atrial structural remodeling are particularly predisposed. This figure by Dr. Stanley Natel reviews early concepts of AFib mechanisms. In panel A, we have a trigger focus in the right atrium with fibrillatory conduction emanating from this source. In panel B, there is a stable reentrant circuit termed a mother wave which sends fibrillatory conduction to the rest of the atria. Finally, in panel C, we have the concept where there is no single source of AFib, rather there are multiple independent wavelets of electrical excitation which are constantly multiplying and being extinguished, and it is this process of wavelet generation that maintains AFib. Concepts of AFib made little progress until the 1960s when Dr. Gordon Moe refined the multiple wavelet hypothesis and presented a primitive computer model which supported his concept. His computational grid was able to support fibrillatory dynamics, where perpetuation of simulated AFib was dependent on the ongoing multiplication of electrical wavelets. Wavelets had the tendency for reentry, yet were typically very short-lived and rarely made complete rotations. Wavelet production was entirely random in time and space, making the maintenance of AFib a probability phenomena. The greater the number of wavelets, the greater the likelihood of AFib continuing. Since it was first presented, this model has provided the leading conceptual framework for understanding AFib, both for clinicians and for basic scientists. Consistent with Moe's multiple wavelet hypothesis, which argued for a substrate-based mechanism, premature atrial beats, or PACs, have long been considered the #1 trigger initiating AFib. As a demonstration, this figure shows a patient implanted with a loop recorder, the Medtronic Reveal Link for AFib monitoring. A low burden of PAF was discovered with overall chronotropic incompetency. A dual-chamber pacemaker was implanted with 90% atrial pacing. The link was not removed and demonstrated a marked increase in AFib burden following pacemaker implantation. This was attributed to the PAC-like effect of atrial pacing. This result demonstrates how AFib initiation can be a substrate phenomena, originating from the atrial chambers without any contribution from pulmonary veins. Much has been done to improve on Gordon Moe's computer model. We now have realistic mathematical models of atrial electrophysiology, giving us powerful and compelling insights into ionic mechanisms. Individual ionic currents are reproduced mathematically, giving a complete mathematical representation of the atrial cell. Here we have some of the equations from the mathematical model of the atrial action potential developed by Rafael Ramirez and Marc Courtemanche at the Montreal Heart Institute, which I used in my PhD studies of AFib dynamics. The model is a coupled system of about 30 first-order ordinary differential equations which are integrated numerically. These mathematical models reproduce many important features of atrial electrophysiology. On the left, we see how regional differences in ionic current densities account for different action potential properties. On the right, we see how atrial tachycardia-induced remodeling markedly shortens the atrial action potential while abolishing rate adaptation. These are powerful pro-arrhythmic effects which leave large portions of the atria vulnerable to ectopic activity initiating AFib and then available to maintain AFib. Here we see a computational tissue substrate. A sinus beat conducts from top to bottom, and then a PAC fires immediately after recovery of the passing wavefront. The PAC spreads with unidirectional block in the direction of the recovering wavefront. The PAC spreads in both directions laterally along the refractory border, and then as the refractory tissue recovers, activation turns towards the newly available excitable tissue, forming two rotors, which perpetuate in a figure-of-8 pattern of reentry, rotating at about 400 beats per minute under baseline conditions, completely dominating atrial activity. This all arises naturally from the fundamental properties of cardiac tissue, which is a network of electrically and mechanically coupled myocytes which form an electrical-mechanical syncytium. The electrical properties of individual myocytes supporting the electrical properties of the syncytium. Tissue-level dynamics being dependent on, but much different from, individual cellular dynamics. It's important to grasp the basic electrophysiologic properties of atrial tissue and understand how the atria can support complex rhythms. We should understand why it's most natural for electrical wavefronts to form spiral waves or reentry circuits known as rotors, and why every instance of wave break is an opportunity for a new rotor to form, where each rotor may potentially take control, driving the AFib until another rotor takes over or the episode terminates. Rotors indeed appear to be attractive ablation targets. But how to locate the rotors and how to know which rotors are critical to AFib? Let's understand how rotors can manifest as complex fractionated atrial electrograms or CFAEs. Let's understand how rotors can manifest in the spatiotemporal dispersion of atrial electrograms, which may be the basis of a novel and emerging ablation strategy. These figures help us understand the fundamental properties of rotors. On the left, we see an activation wavefront that has formed a rotor, as in the prior slide. Along the wavefront, the amplitude of the action potential gives the energy for forward conduction, indicated by the white arrows on the right. The wavefront curvature establishes the source-sink relationship or activation energy reserve for forward conduction. With a linear wavefront, each activated cell, the source, must provide activation energy for a single cell, the sink, in a one-to-one relationship. With a convex rotational curvature, as is the case for rotors, activated cells or source cells must excite a larger number of cells at rest, the sink. Wavefront rotation occurs with a lower safety factor for conduction in the case of a convex rotational curvature. The thickness of the wavefront is determined by the action potential duration, which is also a determinant of the energy available for forward conduction. The thickness of the wavefront is diminished towards the tip of the rotor due to an increase in hyperpolarizing currents, mainly IK1 current, acting through the electrical syncytium of cells along the rotor. As we move towards the rotor tip, we see the rotor curvature tightening, while the thickness of the wave is decreasing. Activation energy for forward conduction is therefore less and less until we reach the tip of the rotor. At the tip of the rotor, the activation wavefront and recovery tail meet at a single point. This is called a phase singularity point, labeled PS, because all phases of the action potential are indistinguishable at the rotor tip, at the PS point. No upstroke means there's no activation energy for cells at rest, and forward conduction fails at the PS point. The wavefront buckles around the phase singularity point, initiating rotation of the wavefront around the phase singularity. As the wavefront turns, the phase singularity does not advance, rather it is redefined at a new location. As rotation continues around a sequence of phase singularity points, a rotor is formed. As the rotor completes each rotation, the consecutive phase singularity points define the core region of reentry. The core has special properties. The core region consists of excitable but non-excited tissue due to the flow of hyperpolarizing potassium current along the rotor into the core. Due to this, subthreshold excitations are occurring within the core such that high-frequency, low-amplitude electrical recordings can be made from within the rotor core, appearing as complex fractionated atrial electrograms or CFAEs. If we can detect CFAEs during our ablation procedures, it is possible that we have discovered a rotor core region and that ablation of CFAEs may disrupt rotors. This slide shows both computer simulations and tissue recordings of rotors from the Khalife lab. Simulations in the left panel show a rotor. Moving along the rotor from point 1 to 2 to 3, we see reduced action potential duration until a phase singularity point is reached. The phase singularity point defines the core of reentry. In the bottom panel, with multiple revolutions of the rotor, we see that the rotor tip traces a flower petal pattern where only a central area of the meander is consistently within the core. On the far right, we see optical recordings of a rotor in cardiac tissue revolving around a core area seen as a blue oval surrounded by orange. In the thick region of the rotor arm, which is orange, large amplitude action potentials are recorded. Within the core, high-frequency, low-amplitude subthreshold recordings are obtained, which we expect to find in the hyperpolarized, excitable but unexcited core region. This is seen again in the middle panel. At the optical center, which is the rotor core, these low-amplitude, complex fractionated electrograms are recorded, with large amplitude signals being recorded from outside the optical center. To summarize, we expect to record complex fractionated atrial electrograms, or CFAEs, from within the core area of rotors. We observe CFAEs frequently during our ablation procedures and recognize now that CFAEs may identify rotors. As we will see, the success of ablation strategies targeting rotors, CFAEs, or spatiotemporal dispersion support the hypothesis that rotor ablation is an effective strategy for eliminating AFib. Let's recognize that the rotor we observe in cardiac tissue, center panel, and the turbulent activity surrounding them are not unique to cardiac tissue. We observe such vortices and associated turbulence in many contexts in nature. As with cardiac tissue, we see similar vortices on the tips of airplane wings, in the formation of hurricanes, and across galaxies in outer space. We know that the eye of a hurricane is calm, much like a rotor core. Each of these vortices represents a distributed system, with organization and influence extending across several inches in the case of cardiac tissue, across several feet in the context of an airplane wing, across miles in the case of a hurricane, and across millions of miles in the case of a galaxy. For each situation, the center of the vortex is highly organized, while activity emanating outward from the center becomes increasingly disorganized. It seems that if we could disrupt the core, the vortex would disintegrate. The galaxy would implode, the hurricane would cease, the airplane would crash, and the AFib would stop. Here we see the process of rotor formation during sinus rhythm, which then degenerates into the complex dynamics of fibrillation. Corresponding optical recordings from cardiac tissue are shown in the gray panels below each color image, demonstrating both a stable rotor and frank fibrillation in cardiac tissue. So far, we've looked at two-dimensional simulations and optical recordings from cardiac tissue, which are sufficient for us to understand the fundamentals of rotor formation and fibrillation. Here we see a model of the three-dimensional atria, which is supporting the complex electrical dynamics of fibrillation. The study shown in the poster draws attention to the fact that the 3D structure of the atria makes an independent contribution to the complex electrical dynamics of fibrillation. During our ablation procedures, we're altering electrical properties of tissue all the time, yet we're stuck with the 3D architecture. Let's at least appreciate that the heterogeneous and discontinuous properties of atrial tissue are making their own contribution to the electrical turbulence of AFib. We can use these tissue models to gain insights into the effectiveness of the ablation lesions we create. Here we see the effects of circumferential pulmonary vein isolation with a linear ablation line across the posterior left atrial wall, allowing us to see why this ablation may or may not influence AFib in a meaningful way. In this case, when AFib is not originating from the pulmonary veins and does not involve macro reentry through the posterior left atrial wall, the influence of these ablation lines is minimal. Let's discuss the contribution of the autonomic nervous system, recognizing that parasympathetic input to the atria through the vagus nerve is an exceedingly potent inducer and facilitator of AFib. This is a case I shared on Twitter, which demonstrates the power of the vagus nerve. We have a 32-year-old woman with syncope. During a tilt table test, she suddenly progressed from sinus rhythm to 2-to-1 AV block to complete heart block, where the sinus rate was progressively slowing following the onset of complete heart block, resulting in a faint. Vagal overactivity was enough to block the AV node and block normal compensatory mechanisms, where sinus acceleration following the onset of complete heart block would be expected. We note that an even stronger vagal discharge could cause complete electrical standstill in the atria due to overwhelming hyperpolarization mediated by the vagus nerve. We're familiar with the broken heart syndrome, or Takotsubo cardiomyopathy, where mental or physical stress initiates a powerful discharge by the autonomic nervous system, causing an outward ballooning of the ventricle, such that the heart takes the shape of a Takotsubo, or Japanese octopus trap. These LV grams further demonstrate the apical ballooning of a stress-induced cardiomyopathy where the LV fails to contract from the mid-ventricle to the apex. The syndrome mimics a heart attack and in rare cases can be fatal. Again, this allows us to appreciate the inordinate power of autonomics on cardiac function. Furthermore, let's appreciate the highly developed neural networks localized to the heart, which are largely independent but certainly modulated by the brain. This system behaves as though the brain offloads certain aspects of its function to the heart, including personality. This can result in the recipients of heart transplant taking on the dominant personality features of the organ donor. In this example, a man named Kevin Mashford received the donor heart of a fellow who died in a cycling accident. Kevin Mashford, who never cared about bicycles before, has since discovered a passion for cycling. In the EP lab, we often map high-frequency complex activity that resembles an electroencephalogram. Seems more like a brain than a heart. In these situations, I wonder if my ablation may disrupt cardiac neural networks, resulting in subtle personality alterations for the patient. Let's explore the complex dynamics of AFib further for a better understanding of how a complex rhythm like AFib can sustain itself. In 2002, as part of my PhD studies, we published the first realistic mathematical model of atrial fibrillation in Circulation Research, which made the front cover of the journal. We simulated AFib in the setting of high vagal tone. In contrast to the findings of the 1964 computer model by Dr. Gordon Moe, we found that AFib depends on the presence of relatively stable rotors. These rotors perpetuate the ongoing formation of short-lived independent wavelets of electrical activity. These wavelets are certainly contributing to AFib, but they are not sustaining AFib. If we observed an overmultiplication of wavelets, these would disrupt the rotors and the episode of AFib would self-terminate shortly thereafter. In other words, when only wavelets were present without an identifiable stable rotor, AFib would not last. This was strong evidence that AFib is ultimately an organized, rotor-driven process rather than a phenomena arising from multiple random, short-lived events. This slide demonstrates vagal effects on atrial electrophysiology and provides the basis for understanding the complex dynamics of AFib. On the left, in panel B, we see shortening of the atrial action potential as recorded under baseline conditions in black and at low, green, and high, red levels of vagal tone. Since action potential duration determines the wavelength of wavefronts in atrial tissue, this marked shortening due to vagal effects proportionately increases the atrial tissue available to support the complex dynamics of AFib. In panel C, we see rate-related shortening of the action potential between stimulation rates of 60 and 360 beats a minute, with the rate adaptation completely abolished by high vagal tone, panel D. The action potential is now consistently very short. This abolished rate adaptation means that when AFib terminates and sinus rhythm is restored, that the action potential won't prolong to maintain atrial tissue in refractoriness during atrial diastole. Rather, the majority of atrial tissue will remain excitable and therefore vulnerable to ectopic events which may induce the next AFib episode. In the middle figure, we see a rotor propagating in a sheet of atrial cells under controlled conditions. The overall activation rate is spontaneously 350 beats per minute. In panel B, we see that the rotor displays a certain meander pattern, which is due to rate adaptation of the underlying action potentials adjusting to the sudden presence of a rotor. The figure on the right shows rotor properties with strong vagal effects applied uniformly across the tissue. The thickness of the rotor or wavelength is now markedly reduced, corresponding to the dramatic reduction in action potential duration. Panel B shows how the rotor is now much more stable with a markedly reduced meander pattern. The overall activation rate is now 1,000 beats per minute, which is 3 times faster than under control conditions. This demonstrates how high vagal tone exerts a strong organizing and stabilizing effect on rotors with a 3-fold acceleration of the rate of rotation. As we will see, this effect explains the complex dynamics of AFib, which is characterized by the presence of rotors and also by independent electrical wavelets. Very stable, high-frequency rotors in areas of high vagal tone emanate wavefronts which break up in regions with longer refractory periods where vagal tone is less. Here we see simulated AFib with vagal effects spread heterogeneously across the tissue, as occurs physiologically. A rotor is formed, which creates zones of refractoriness with each revolution, and breakup begins to occur as subsequent wavefronts encounter tissue areas that are still refractory from prior activations. While the model substrate seems simplistic, the number of wavelets produced, the lifespan of wavelets, the rotors which form, and number of revolutions completed by both short-lived and sustained rotors agrees closely with experimental measures. It is readily apparent that rotors are more stable and turn much faster in regions of high vagal tone, with emanating wavefronts encountering refractory tissue in the periphery left over from prior activations. Complex interactions ensue as zones of prolonged refractoriness are recreated when excitation does occur, or further breakup results when refractory tissue is encountered, which is closely followed by new rotor formation as wavelet tips are able to then re-enter zones of recovering excitability. The process of fibrillation in normal-size atrial tissue is a rotor-dependent process. A relatively stable rotor is always present, which drives fibrillation. If a dominant rotor is extinguished, another rotor quickly assumes dominance and maintains the AFib. We found that when a dominant rotor was not clearly present and fibrillation was dependent on the constant multiplication of short-lived wavelets, that the episode of AFib would soon terminate. Referring back to historic conceptions of AFib, the presence of a mother wave appears to be the most accurate. Gordon-Moh's multiple wavelet hypothesis fails to account for AFib in normal-size atria. Here we see simulated AFib when atrial size is increased. We see the evolution of a single rotor leading to complex patterns of breakup. The phase singularity points, or PS points, are tracked, allowing us to follow the original rotor and identify new rotor formation. The most stable PS points are green, while the shortest-lived PS points are red. Tracking PS points allows us to determine whether AFib is ultimately a rotor-driven or wavelet-driven process. When atrial size was increased, many AFib episodes became truly wavelet-dependent, validating Gordon-Moh's multiple wavelet hypothesis in the setting of increased atrial size. However, this only occurred sometimes, even when atrial size was increased beyond physiologic. This indicates that AFib is fundamentally a rotor-driven process that is modulated by the presence of triggers, fibrosis, stretch, autonomic ganglia, and other types of remodeling. A valid model of AFib allows us to study antiarrhythmic drug mechanisms. Class 1C antiarrhythmic drugs, the strongest sodium channel blockers available, are historically the most successful class of medications for terminating AFib, but also the most poorly understood mechanistically. The most common examples of 1C drugs are flecainide and propafenone. These are more frequently used for controlling paroxysmal AFib and are appropriate in the absence of myocardial ischemia and when LV ejection fraction is preserved. In this simulation, the termination mechanism is readily apparent. An episode of AFib is initiated with 65% sodium channel inhibition then applied. Termination is attributable to decreased excitability resulting from reduced action potential amplitude and upstroke kinetics, as these are diminished by sodium channel block. The wavelength is also shortened due to less recruitment of plateau currents, which prolong action potential duration when fully activated by a non-attenuated upstroke. The wavefront curvature flattens due to the decreased excitability, compensating for the lower safety factor for forward conduction. As a result, the rotor is not able to turn tightly, which makes it vulnerable to termination. It is vulnerable as it is less able to fit on the available tissue, which makes it more likely to extinguish along structural discontinuities or zones of electrical refractoriness. We published these results in Circulation Research in 2005. Here we see experimental validation of the simulation results. Optical recording of AFib in preparations of sheep atria are shown under control conditions and with low and high levels of sodium channel block. The slowing of AFib dynamics with decreased complexity is apparent. These experiments were performed by Dr. Jérôme Khalifa, who I first met in Montreal in 1999 during my PhD studies at the Montreal Heart Institute. Jérôme had completed his clinical cardiology fellowship in France and was anxious to commit his career to basic science research. Later, we will review Dr. Khalifa's 2017 paper in JACC proposing a novel approach to AFib ablation based on spatiotemporal dispersion. Understanding AFib and electrophysiologic phenomena better, we will discuss strategies for catheter ablation beginning with the conventional approach that typically includes pulmonary vein isolation and ablation lines, usually a left atrial roof line or mitral isthmus line. We will also review the potential role for left atrial appendage isolation and coronary sinus isolation under the conventional approach. For the conventional approach, the grand unified theory of AFib is that the venous insertions into the atria are the sources of fibrillation. These include, number one, pulmonary vein insertions. In fact, the entire posterior left atrial wall is essentially a single large pulmonary vein antra, making the pulmonary veins the greatest venous contributors to AFib. Number two, the coronary sinus, which courses along the postero-inferior left atrial wall. Number three, the superior vena cava, which also may be a source of triggers and require isolation. Four, the ligament of Marshall, which represents the embryologic remnant of the left SVC along the posterolateral left atrial wall, a dried creek bed in most of us, but of venous origin, which can display spontaneous bursts of high-frequency trigger activity. Conventional approaches also seek to neutralize arrhythmogenic areas of fibrosis and scar, autonomic ganglia, and macro reentry using empiric linear lesion sets. While these are often applied somewhat blindly, it is no surprise that they are frequently helpful and remain in the ablationist armamentarium. Later, we will discuss a CFAE-guided approach to linear lesion placement, discussing how strategically placed lines may best neutralize the AFib substrate. This cartoon reflects the diversity of opinions about AFib and approaches to AFib ablation, which are also influenced by operator experience, ability, and stamina. This slide illustrates the stepwise conventional approach to AFib ablation, which represents the starting point for most operators. Circumferential antral pulmonary vein isolation is the cornerstone of the conventional approach and considered sufficient for ablation of paroxysmal AFib. In the bottom images, we see point-by-point ablation for antral pulmonary vein isolation, which can also be performed using a dragging or gliding motion of the catheter. For persistent or long-standing persistent cases, particularly when appreciable structural heart disease is present, operators may choose to add linear lesion sets to form complete lines of block, typically a left atrial roof line or mitral isthmus line, while ablating additional trigger sites identified outside the pulmonary veins. How many lines to perform and how many trigger sites to target remains an area of active debate, with significant differences found between labs. This figure shows paradigms for pulmonary vein isolation by leading experts in AFib ablation, with different strategies for ablating through the carina region, separating the left and right pulmonary veins. In general, we see a minimalist approach, where ablation lesions are delivered as efficiently as possible to encircle the veins. Such clear lesion sets demonstrate excellent catheter skill, much like great swordsmanship. Natali's more extensive approach to pulmonary vein isolation is illustrated. Ablation is performed around the veins, with lots of additional ablations within the antral regions. This is to neutralize other AFib mechanisms scattered around the vein insertions, including autonomic ganglia, triggers, rotors, and CFAEs, which may be neutralized without being clearly identified, still getting the most durable result for the patient. Using high energy and swift dragging or gliding catheter movements, operators like Natali can perform extensive ablations in a timely manner. In general, Natali recommends extensive ablation, more instead of less, an approach which has greatly influenced my practice. A Natali approach to pulmonary vein isolation will also include extensive ablation over the posterior left atrial wall, and this is because the posterior wall and pulmonary veins derive from the same embryologic tissues and therefore share the same properties. Ablation should be applied generously around the veins and over the posterior left atrial wall. We are reminded that performing PVI at the level of the antra is preferred rather than at the level of the pulmonary vein insertions into the atrial chamber, also known as the ostia. There is less AFib recurrence with atrial ablations and also less chance of pulmonary vein stenosis with this approach. In addition to electroanatomic mapping, intracardiac echo or ICE can and should be used to identify the atrial region, which may do a better job of confirming that we are truly removed from the ostial region. And finally, it's important to actually achieve pulmonary vein isolation, labeled PVAI, as opposed to simply ablating around the pulmonary veins without confirming isolation, labeled CPVA. Durable isolation with bidirectional block should be confirmed when pursuing a conventional approach to AFib ablation. Natale also advocates for isolation of the left atrial appendage, which he found to account for 27% of repeat ablation procedures. Sites of earliest activation were targeted either during sinus rhythm or AFib, with only limited ablation lesions needed to achieve isolation. See the left figure, bottom panels. On the right, panel A shows recordings from a circular mapping catheter within the ostia of the left atrial appendage. The earliest site of activation is identified by the arrow. Panel B shows a change in activation sequence after ablation of the earliest signal with a new earliest site emerging. When this second earliest site is ablated, left atrial appendage isolation is suddenly achieved. This figure shows the contribution of left atrial appendage isolation to freedom from AFib. The blue lines show how AFib recurrence is markedly less when left atrial appendage isolation is included in both a first and second ablation procedure. CFAEs, or Caffey-like signals, are frequently displayed by the coronary sinus catheter during AFib, particularly along the more proximal poles. Both Dr. Natale and Dr. Nadamani believe that CS isolation is frequently needed to complete a successful AFib ablation. This has certainly been our experience. CS isolation typically requires ablation from within the CS, although ablation along the CS from the left atrial side may also contribute. The left panel shows the overlap of CS musculature and left atrial musculature along the CS. The CS musculature attenuates along the CS while the left atrial musculature is relatively constant. The figure on the right shows freedom from AFib following CS isolation, the blue line, versus only focal CS ablation along the CS but without isolation, the red line, demonstrating the relative importance of CS isolation. Ablation within the CS raises safety concerns about collateral damage of the coronary arteries, which has been known to occur with ablation of accessory pathways within the proximal CS. Coronary arteries tend to run along the inferior CS anteriorly. For a right dominant system, the right coronary artery or posterolateral artery is superficial to the CS over a distance of 1 centimeter, beginning about 1 centimeter beyond the CS os. The same is true of the left circumflex artery in the left dominant coronary system. Given that we don't know whether a patient is left or right dominant at the time of their AFib ablation, it is our practice to direct the ablation catheter towards the posterior-superior aspect of the CS, which should be closest to the left atrial myocardium and furthest from the coronaries, over the initial 3 centimeters of the CS in particular. While Natale suggests using 35 watts and rapid motion within the CS, our approach is to use 10 to 15 watts with contact force 5 to 10 grams. This is with a Biosense Webster surround flow contact force sensing catheter within the coronary sinus. When performed towards the end of an extensive ablation procedure, CS isolation often results in AFib termination. This slide summarizes the conventional approach to AFib ablation. In the majority of labs, atrial pulmonary vein isolation is all that is performed for paroxysmal AFib, with the possible use of isopril to assess for triggers. Steps for a more aggressive approach to paroxysmal AFib, as Dr. Natale would perform, are shown in blue text. These include posterior wall isolation and truly high-dose isopril to assess for triggers. Natale suggests to start with isopril 20 mics per minute and continue for 10 minutes. He indicates that the trigger-inducing effects of isopril is lost when starting at lower doses. Anesthesia may need to use pressors to compensate for hypotension while isopril at these doses is given. For persistent AFib, antral PVI is performed with linear lesion sets used to create lines of block across the left atrial roof and mitral isthmus. Isopril is then used to assess for triggers, which are targeted and ablated. For a more aggressive approach to persistent AFib, isolation of the posterior left atrial wall, left atrial appendage, and coronary sinus are performed with linear lesion sets to create complete lines of block in locations where extensive ablation has inadvertently created incomplete lines. This is to prevent macro-reentrant circuits, which may develop when narrow isthmuses are created by ablation performed for other reasons, such as ablation of adjacent dense CFAE nests. Understanding conventional approaches, let's move on to less conventional approaches which can be highly effective when performed correctly and in the right patient. Such approaches include rotor ablation, CFAE ablation, and substrate ablation targeting spatiotemporal dispersion. We see the prominent role that rotors play in the process of fibrillation and how every instance of wave break results in the formation of a phase singularity point which may evolve into a stable rotor. Fully understanding the fundamental process of rotor formation in atrial tissue and recognizing the potential for rotors to sustain AFib, Dr. Sanjeev Narayan developed the FIRM algorithm for focal, impulse, and rotor modulation to detect and localize rotors as ablation targets. This has been marketed under the name Topera, which was purchased by Abbott. For a process such as AFib, targeting rotors seems self-evident. By eliminating the drivers of AFib, AFib should no longer occur and the patient will experience freedom from AFib. As this figure shows, FIRM has relied on an 8-spline basket catheter with a total of 64 poles, which is deployed sequentially in both the right and left atria, sampling the entire atrial chamber at once to identify rotors. Now, we know that rotors are frequently transient and that mechanistically important rotors may be in different locations at different times. It is therefore questionable whether an 8-spline basket catheter can reliably identify which patients have rotor-based AFib and localize the critical rotors to guide a successful ablation procedure. The FIRM algorithm has been with us as a clinical tool for 5 to 6 years now, and we can ask, how has FIRM performed? Overall, there is a conflicting literature. However, it seems that truly independent groups and many of the best AFib ablation programs nationally are not supportive. When considering the use of FIRM, every electrophysiologist should be aware of the OASIS trial. The OASIS trial was designed to be a definitive evaluation of FIRM. OASIS was presented as a late-breaking clinical trial at the Heart Rhythm Scientific Sessions 2016 and published in JACC 2016. OASIS randomized 113 patients undergoing first-time AFib ablation to FIRM only, FIRM plus PVI, or PVI plus posterior wall and non-pulmonary vein trigger ablation. FIRM mapping was repeated until all rotors were identified and ablated, or AFib organized into atrial tachycardia or converted to sinus rhythm. An average of 4 rotors were detected in all FIRM patients. FIRM performed poorly in OASIS. The FIRM alone arm was stopped early for futility, and the FIRM plus PVI group performed worse than PVI alone. OASIS was later retracted from the literature over concerns about randomization and trial registration. Industry interference in the retraction has been strongly suspected. In its present form, FIRM does not appear to adequately map rotors for a rotor-based approach to AFib ablation. Nevertheless, we know that rotors are fundamental to the process of fibrillation. I anticipate that improved high-resolution mapping will demonstrate which patients have rotor-dependent AFib and which rotors are the true drivers of AFib in those patients, allowing for effective rotor ablation. AFib ablation may also be performed based on identifying and targeting complex fractionated atrial electrograms, or CFAEs. We have already seen how CFAE-like signals are expected to rise from the core regions of rotors and may therefore serve as surrogates for the presence of rotors. CFAE-guided ablation was developed by an electrophysiologist of enormous stature in the field, Dr. Kunlawi Nadamani, who first described CFAE-guided ablation in JACC 2004. Dr. Nadamani recognized that during AFib, CFAEs would be expected to occur at areas of slow conduction and at pivot points where wavelets turn around the ends of zones of functional block, representing continuous reentry of the fibrillation waves into the same area. Dr. Nadamani believed that if areas of CFAEs identified were wavefronts complete reentry, that such areas could be eliminated by catheter ablation and AFib would stop. This is analogous to saying that regions reliably displaying CFAEs correspond to regions with stable dominant rotors and that ablating regions where dominant rotors occur should stop AFib. In the Jack 2004 paper, durable CFAE sites were defined as low amplitude deflections, less than 0.25 millivolts, with very short cycle length, typically less than 120 milliseconds, which were continuous over a 10-second interval. The orange arrow points to recordings of CFAEs in the posterior septum and left atrial roof. We need to be aware that in the 2004 studies, all CFAEs were identified by mapping point by point using an ablation catheter, which were used to carefully sample the entire atria, including the left atrial floor and inner atrial septum. When all CFAE locations were identified, those sites were sequentially ablated, beginning with the most extensive CFAE nests. When CFAE ablation is complete in the left atrium, the ablation catheter is withdrawn into the right atrium and the process of CFAE mapping and ablation is repeated. The ablation catheter is advanced deep into the coronary sinus with CFAE ablation performed throughout the CS. The proximal CS is most likely to display CFAEs. When ablating within the proximal CS, it's important to avoid the inferior wall or floor of the CS, where either the right coronary artery or left circumflex artery may run superficially with risk of thermal injury. While CFAEs are frequently found and ablated at the pulmonary vein antra, circumferential pulmonary vein isolation during a CFAE ablation procedure is not pursued. It is presently possible, through Biosense Webster, to visit Dr. Nadamani's lab at White Memorial Hospital in Los Angeles. We may sit with Dr. Nadamani as he performs CFAE ablation. I have taken this opportunity twice and hope to visit for a third time. The experience is amazing. You're watching one of the true masters in our field. In a patient with long-standing persistent AFib with exceedingly complex atrial activity seeming to come from everywhere, you observe as AFib progressively slows, organizes into a regular tachycardia, and then terminates with additional consolidative ablation in areas where dense CFAE nests were initially found. 14 years after the CFAE method was first published, Dr. Nadamani and Dr. Khalifa authored a paper in Heart Rhythm 2016 in defense of CFAE ablation. The need for a defense article reflects the fact that CFAE ablation has not been readily reproduced in other labs and consequently not gained widespread support. This article suggests that CFAEs are not adequately mapped or accurately identified, accounting for the disappointing results in other labs. The defense article expands the definitions of CFAEs, which makes sense to us given what we know about rotor properties. First, CFAEs may represent areas of slow conduction or pivot points, with pivot points behaving like rotor cores. Second, CFAEs may represent continuous reentry in the same area, which should behave like a rotor core region. Third, CFAEs may represent parasympathetic ganglia, or regions of high vagal tone, and this is where we would expect to find stable, high-velocity rotors driving AFib. Fourth, conduction through fibrotic tissue is expected to contribute to the CFAE-like appearance of local electrograms. Politely, the authors propose that the reason why other labs have difficulty with CFAE ablation is because of inconsistencies in recognizing CFAEs and deciding which to ablate. In the left panel, CFAEs are recognized from the inner atrial septum on the right side, indicated by the 3 pink asterisks. Key features are the multiple low-voltage potentials with cycle lengths 50 to 120 milliseconds, which are essentially continuous, extending between the major activation complex seen on adjacent poles. In the middle, we see CFAEs from the right inferior pulmonary vein, indicated by 3 pink asterisks. Activation is regular but high frequency, with cycle length 100 to 115 milliseconds. As this is the location with highest frequency, it represents the driver region of AFib in this patient. The right panel further clarifies a true CFAE indicated by 3 pink asterisks from what may be confused as a CFAE indicated by 3 blue asterisks. The true CFAE has continuous activation without any consistent electrical silence between major complexes. The bad CFAE has complex interactions, however this is not continuous. There is consistently electrical silence between major complexes. CFAEs to target for ablation are low voltage, 0.04 to 0.25 millivolts with short cycle length, 50 to 120 milliseconds, having stability in both space and time. In contrast, sites not for ablation have electrograms that are high amplitude with longer cycle length and which are fleeting in space and time. CFAE ablation takes practice, and there's a difference between the promising beginner and a grandmaster. I highly recommend visiting Dr. Nadamani's lab at White Memorial Hospital in Los Angeles to watch a masterful ablation targeting CFAEs. He will assess every left atrial site with an ablation catheter to assess for the presence of CFAEs. When all CFAE locations have been tagged, these sites are sequentially ablated, beginning with the most extensive CFAE nests. When work is completed in the left atrium, the ablation catheter is withdrawn into the right atrium and the process is repeated. The ablation catheter is advanced deep into the coronary sinus with CFAE ablation performed throughout the coronary sinus. An important aspect of Dr. Nadamani's CFAE ablation is the use of ibutylide. Following a detailed CFAE ablation, when AFib continues, ibutylide 1 mg IV may be given. This organizes bystander electrograms without affecting true CFAEs. This allows for remaining relevant CFAEs to be identified and ablated, which often terminates AFib. The location of these final CFAEs is usually within or around CFAE nests ablated earlier. Prior ablation sites are re-explored, reinforced, and slightly expanded with consolidative ablation. Rarely are new CFAE sites identified at this stage of the procedure. Extending the CFAE concept, Dr. Khalifa published an approach to AFib ablation based on spatiotemporal electrogram dispersion in JACC 2017, again without pulmonary vein isolation. In contrast to original papers mapping and ablating CFAEs, the Biosense Webster 20-pole pentarray catheter was used to map the atrial substrate. This is intriguing to me since the catheter configuration I already used for AFib ablation was used in this study. The Biosense Webster 20-pole pentarray mapping catheter and Biosense Webster contact force sensing surround flow ablation catheter. The pentarray catheter was used to map atrial electrograms in space and time simultaneously. Areas displaying spatiotemporal dispersion were visually identified as electrograms showing no orderly progression between adjacent poles. In regions with spatiotemporal dispersion, CFAEs were identified on certain poles of the pentarray catheter. Ablation was then performed over the entire region, demonstrating spatiotemporal dispersion, including those sites with CFAEs. This was reminiscent of Dr. Nadamani's technique, where he sometimes returns to areas of ablated CFAEs, expanding the ablated area to achieve AFib termination. This practice may be neutralizing spatiotemporal heterogeneity or dispersion, as shown here. On the right, pentarray recordings showing spatiotemporal dispersion are seen with 3 pink asterisks. There is no obvious progression of activation complexes on adjacent splines. Below this, pentarray recordings without spatiotemporal dispersion are seen for comparison with 3 blue asterisks. The linear progression of activity between adjacent splines is readily apparent, indicating the absence of dispersion. Ablation is performed over all poles showing spatiotemporal dispersion with 3 green asterisks. Panel B shows that both fractionated and unfractionated signals are recorded from within a region of spatiotemporal dispersion. Again, unlike the method of CFAEs where only the fractionated atrial electrograms are ablated, the method of spatiotemporal dispersion targets all electrograms within the region of dispersion. This figure shows more examples of dispersion versus non-dispersion. CFAEs are observed on some poles within regions displaying dispersion, but not all poles. Ablation is performed throughout the region of dispersion, encompassing both fractionated and unfractionated electrograms. Khalifa used spiral wave theory to demonstrate how rotors may account for the spatiotemporal dispersion seen during ablation procedures. In panel A, the pentaray is positioned in the middle of the rotor. Electrograms recorded along the pentaray spline display spatiotemporal dispersion without any of the poles displaying CFAEs. In panel B, we see pentaray recordings from the periphery of a rotor. Electrograms are much slower and no dispersion is seen from outside of the rotor. In panel C, the pentaray is again positioned in the center of a rotor, this time in tissue with extensive fibrosis. Electrograms are wider due to the presence of fibrosis, with a high degree of dispersion remaining. This data shows how regions of dispersion can reflect the presence of rotors even when CFAEs are not seen, indicating that ablation targeting dispersion may eliminate rotors in locations not displaying CFAEs. On the left, we see optical recordings from the right atrium and left atrium during AFib. A rotor is clearly present in the left atrium, with the right atrium being passively activated by activity emanating from the left. On the right, corresponding pentaray recordings are shown below the right and left atrial maps. The left atria displays a high degree of dispersion, while the right atria remains well organized. The difference clearly distinguishes the left atria as a driver region where an underlying rotor is likely present. In this series of 105 patients with all types of AFib, patient-tailored ablation was performed based on pentaray mapping of dispersion areas. In the top panel, driver regions are shown during AFib, with these areas successfully ablated. In the bottom, more examples of ablated areas based on dispersion are shown. Here we see the overall results from this approach. In panel A, there was 95% AFib termination during ablation, either directly to sinus rhythm or to an atrial tachycardia and then sinus rhythm. Non-inducibility testing was performed in 58%, with non-inducibility achieved in 72%. In the bottom panels, we see that RF time and procedure time to terminate AFib were longer for long-standing persistent AFib. However, total RF time and total procedure time were not significantly different between paroxysmal, persistent, and long-standing persistent cases. Khalifa's ablation strategy targeting spatiotemporal dispersion is particularly compelling since it used the same catheter setup we use for our ablation procedures. We use the surround flow contact force sensing ablation catheter by Biosense Webster with the 20-pole pentaray mapping catheter. These catheters are shown schematically as they appear fluoroscopically and as represented by the 3D electroanatomic mapping system. We have attempted to develop an approach to AFib ablation using the best available techniques, applying each technique to each patient as appropriately as possible to achieve a patient-specific, customized ablation with best possible outcome. To achieve this, we have proposed a CFAE-guided approach to pulmonary vein isolation and published this as an article describing the method in EP Lab Digest 2014. Ideally, the patient presents an AFib or AFib is induced in the lab if needed, and CFAEs are mapped using the pentaray catheter throughout the left atrial chamber. Antral pulmonary vein isolation is then performed in a way that eliminates as many CFAE regions as possible during pulmonary vein isolation. Following pulmonary vein isolation, additional CFAE sites are ablated with consideration for regions of spatiotemporal heterogeneity. When CFAE ablation comes close to forming traditional linear lesion sets, such as across the left atrial roof or mitral isthmus, these lines may be completed to avoid the creation of macro-reentrant circuits. Per Dr. Natali, complex signals with earliest activation along the left atrial appendage may be ablated with isolation of the CS from the left atrial side and by ablating within the CS. With the ablation catheter withdrawn into the right atrium for ablation within the CS, CFAEs are mapped within the right atria as well, with particular attention paid to the interatrial septum and crista terminalis. During this approach, AFib will slow and organize, often resolving into an atrial tachycardia or micro-reentrant flutter, which is then ablated, restoring normal sinus rhythm. When AFib has not organized into a discernible mechanism following this ablation process, ibutylide 1 mg IV may be given over 10 minutes, which simplifies bystander signals while retaining the complexity of residual relevant CFAEs. These may be targeted and ablated, then restoring sinus rhythm. Here are some figures from our article in EP Lab Digest on CFAE-guided pulmonary vein isolation. The Penneray catheter is used to create a detailed electroanatomic map representing the left atrium, pausing in each location to allow CARTO to compute the presence of CFAEs. CFAEs detected with high confidence are assigned a red dot, while CFAEs with intermediate confidence are given blue dots. Both red and blue dots are explored with the ablation catheter and ablated if appropriate. Panels in the middle show how CFAEs are often clustered in the pulmonary vein antral regions. Panels on the right show how pulmonary vein isolation is expanded to incorporate areas of CFAEs, creating a broader pulmonary vein isolation lesion set as Natali encourages us to perform. Here we see rapid, complex CFAE signals given red tags by CARTO and complex EGMs given blue tags. Adjacent areas with slower, more discrete, and regular activity are also displayed. These are truly bystander regions with little relevance to the process of fibrillation. This figure shows an example of CFAE-guided pulmonary vein isolation for paroxysmal AFib. We can appreciate how CFAEs were identified within the antral region of both the left and right pulmonary veins. In this case, CFAE-guided pulmonary vein isolation means to simply expand lesion sets to incorporate CFAEs within the antral regions. This figure shows an example of CFAE-guided pulmonary vein isolation for long-standing persistent AFib. In this patient with an advanced cardiomyopathy, a thorough and successful ablation procedure was needed. The figure illustrates CFAE-guided PVI with ablation of CFAEs throughout the antral regions, ablation of dense CFAE nests found along the anterior left atrium as well as the lateral right atrium. Limited ablation lesions to isolate the CS are shown, as well as extensive ablation from within the CS for complete isolation of the CS. Termination of AFib was achieved after an extensive procedure with ablation of CFAEs along the posterior CS os. Ablation technique has been greatly improved with contact force sensing catheters. This data demonstrates the importance of the stability of applied contact force. Procedural success was the highest when contact force was maintained over 80% of the time. It is presently recommended to keep contact force above 5 grams and below 15 grams. Operators may strive to maintain contact force between 8 to 12 grams for optimal results. Here are ablation parameters that Dr. Natali would suggest with irrigated catheters. He suggests to start at 40 watts, reducing power to 30 to 35 watts over the esophagus. Apply power for 10 to 15 seconds. Recognize that low power, 20 to 30 watts, is associated with non-transmural lesions. Interestingly, Dr. Nadamani states never to go to 50 watts with a Biosense Webster surround flow catheter. Keep contact force below 15 grams. Recognize that higher contact force does not improve ablation lesions. It only creates edema, which limits lesion formation. Do not increase power when the catheter tip is orientated perpendicular to the atrial wall. Within the CS, use 35 watts for 5 to 10 seconds with quick movement and avoid the inferior CS, particularly the anterior aspect of the CS floor. Always monitor the impedance. 10 to 15 ohm drops indicates effective ablation. Stop ablating if impedance suddenly rises. At the end of the ablation procedure, we assess for residual triggers with Isopril IV. The top left panel shows that triggers can arise anywhere in the atria. The top right panel indicates that P-wave morphology can suggest the trigger site of origin. It is best to position the available catheters to represent as much of the atria as possible, as shown in the fluoroscopic image. The more catheters the better for this, with intracardiacs best identifying the earliest atrial activations. Natali recommends to begin with Isopril 20 mics per minute for 10 minutes. He feels that the ability to elicit triggers is lost by starting at lower doses and ramping up. Anesthesia may need to compensate for hypotension while Isopril is given. Having advocated for a rather aggressive approach to ablation with a rigorous attention to substrate for persistent AFib, we must recognize that PVI only may be considered sufficient for a first ablation procedure for persistent AFib, particularly when minimal structural heart disease is present. We note that a simple pulmonary vein isolation procedure may be performed using the cryoballoon. Frequently, however, an RF catheter is needed for touch-up to achieve isolation, increasing procedural cost and duration. Also, we do not know how the cryoballoon compares to a contact force sensing RF catheter with an experienced operator applying stable contact. Many experts believe RF would be vastly superior under these circumstances. Faculty at UCLA feels strongly about a PVI-only approach to persistent AFib. Quotes, "Until better evidence for the benefits of extra PVI ablation is available, it should no longer be seen as irresponsibly conservative to target only the pulmonary veins in an initial ablation procedure for persistent AFib." Again, we maintain that is in patients with no evidence for structural heart disease. It remains that a limited number of patients with persistent AFib have minimal structural heart disease, and the question immediately rises what to do for the redo procedure in patients with persistent AFib initially treated with PVI only. Surely it would then be prudent to draw on the array of techniques that we have reviewed here. To summarize, we have reviewed the stepwise conventional approach to AFib ablation, considering key structures including the left atrial appendage and coronary sinus. We discussed emerging techniques including rotors, CFAEs, and spatiotemporal dispersion. We discussed the role of ibutylite to clarify AFib mechanisms and how to elicit residual triggers towards the end of our procedures. We reviewed recommendation for ablation parameters and contact force. Most of all, we tried to understand the fundamental electrophysiologic processes underlying AFib and to recognize those processes in the EP lab. By practicing in this way, we are able to use a full range of ablation techniques to deliver a patient-specific, customized procedure which should give the best long-term results for each patient. We look forward to advances in mapping, which help us understand and use emerging approaches targeting rotors, CFAEs, and spatiotemporal dispersion.